Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel and I'm your host of the show. And first off, thank you to everyone that's watching this on replay. I know we get always a large number of people watching this on replay, but if you are here watching this live, please type your questions into the chat pad or connect with me live on the show. Last two times we had people on the show here that wanted to talk to me directly. It turned out into quite some lengthy sessions, and I just put the link in the stream in the comment section. So before we go into today's questions, what makes me qualified to host an emergency questions and answers for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I am a critical care nurse by background, and I have worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager in critical care for over 5 years. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And we have been consulting and advocating families in intensive care all over the world. And I can very, very confidently say that we have saved many lives for our clients in intensive care. And you can verify that on our testimonial section at intensivecarehotline.com. And you can verify it on our intensivecarehotline.com podcast on our podcast at intensivecarehotline.com. I am also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are sending our critical care nurses into the home for predominantly long-term ventilation with tracheostomy, and but also for ventilation without tracheostomy like BiPAP, CPAP. We are also providing tracheostomy care at home without ventilation. We're providing home TPN, home IV potassium, home IV magnesium infusions, home IV antibiotics, central line care, PICC line care, Hickman's line care, as well as portacath management at home. We're also providing ventilation weaning at home, nasogastric tube management, PEG tube management, as well as palliative care at home. With intensive care at home, we are sending our critical care nurses into the home 24 hours a day, and we're providing a genuine alternative to a long-term stay in intensive care. With intensive care at home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved all around the country, WorkSafe and TAC in Victoria, iCare in New South Wales, NIISQ in Queensland, DVA all around the country. Our clients have received, and we as a provider have received funding through departments of health, private health funds, as well as public hospitals. So we're also providing level 2 and level 3 NDIS support coordination for intensive care at home, and we're also providing TAC and WorkSafe case management in Victoria. Peter, good morning to you at the Gold Coast. So nice to see you again. Type your questions into the chat pad. In the meantime, I will start with the first question that came in during the week. And like I said, if you want to talk to me directly here, click on the StreamYard link that I posted in the chat pad, or type your questions into the chat pad and I will get to them there. So let's look at an email from Jonathan, who says, "Hi Patrick, my mum, Nonnie, has been in ICU since January the 20th, 2025 with ARDS. She was treated with antibiotics for UTI, blood infection and pneumonia. She's been on the ventilator from day 1 for low oxygen levels and high CO2. So what does ARDS mean? Before I carry on with the email, ARDS means acute respiratory distress syndrome, also known as lung failure. She is comorbid with 2 stage 4 pressure areas on her back. She's dementious and she's got third space fluid buildup in several locations. The ICU team does breathing tests each day to extubate, but hasn't seen a good response. About 5 days ago, she went 8 hours breathing, the next day 6 hours, and the past few days are less than a minute before going back to assisted ventilation breathing. She is awake, eyes open, not appearing in pain, and blood pressure, pulse, oximeter, and testing has somewhat stabilized electrolytes, but full blood count results indicate weak red blood cells and hemoglobin levels. No plasma has been given. I am pressured daily to let her go peacefully with pain management to start before they remove the ventilator and the breathing tube, and they say she will likely pass within hours. The ICU doctors say risk of VAP or other issues with current poor health are not surmountable and increase daily if on the ventilator. So what does VAP stand for? VAP stands for ventilator-associated pneumonia. Well, Jonathan is right in saying that, and even the ICU is right in saying that the risk of a VAP, or ventilator-associated pneumonia, is higher the longer someone is ventilated. That is correct. However, if you take out a ventilator because of the risk of VAP, that means the patient is potentially dying. So which risk are you taking? That's like saying we stop eating and drinking in case food or water is contaminated. Right? It's the same logic. There is no logic in that. You just got to make sure if you are ventilating a patient, you do it appropriately and safely, and you do it with the right intent to wean someone off the ventilator as quickly as possible, ideally. So Jonathan continues in his email. I am reluctant to remove ventilator just as yet in hopes she would regain the desire to inhale on her own, but they say dementia likely is causing brain signals to be weak for stimulating the diaphragm to take breaths. Since her eyes are open and she's salivating and she's responding to my touch, or if I do suctioning, I know that she is still aware enough to see me, etc., but I can't communicate to be sure of much more. The doctor says outlook is poor and pain may exist, but we can't tell as the tube prevents vocalizing sounds to convey this. Well, Jonathan, my advice here is, yes, your mum can't talk, but there are non-verbal pain assessment tools in ICU. And they're very good assessment tools. But I also argue you know your mum, and you can probably tell just by looking at her whether she's in pain or not. You don't need to be a rocket scientist to make that assessment, I believe. So Jonathan continues. I've been pushing back on their wish to limit or eliminate ventilator support and terminate life support because of the 10 to 14 day limit. They say ventilation usually follows for a successful outcome. Backstory. 8 months ago, she was in the same ICU 6 days on the ventilator and recovered to home care and back to baseline within a month. Thus, ultimately, we might win a battle, but won't win the war, as it won't make her life much more. In my mind, I'm willing to hold off on the day 14 mark, so long as I see her awake and she's interacting with me. As I'm the only child and caregiver and proxy, I will have to make decisions, be her advocate, as I've done for the last 4 years with dementia, as well as other medical issues like pressure, ulcers, wound care. It's not going to be easy to let her go. I have been reading through your online materials, trying to grasp at straws of optimism for a possible turn of events, getting off the ventilator even after 11 days on it now. Am I backing her into a corner of suffering while I resist the doctor's advice to go with morphine and removing ventilation support? Am I backing her into a corner of suffering while I resist the doctor's advice to go with morphine and removing ventilator support? I'm sure there's more to consider, but I'm overwhelmed with ideas. I'd be pulling the rug out when she may regain the strength or brain signals to get back to breathing without the ventilator. Thank you for your website and your time, from Jonathan. Well, Jonathan, thank you so much for sending this email, because I think this is a really good email, and I will break this down step by step. So she's got ARDS. That's not a good thing. You know, some patients with ARDS actually need to go on ECMO. And of course, with ARDS, she would automatically have low oxygen levels and high CO2. ARDS stands for acute respiratory distress syndrome, and it basically means lung failure. It basically means when you look at patients' chest x-rays, it's often a complete whiteout, which means to even achieve gas exchange, i.e. oxygen getting in and carbon dioxide going out, is a real challenge. So you would have poor chest x-rays, you'd have very poor arterial blood gases, right? And it's a real challenge to ventilate a patient. Now, she's got pressure sores, she's got dementia, and she's got third space fluid built up in several locations. So with the third space fluid built up in several locations, probably a result of low albumin, low hemoglobin. Once albumin and hemoglobin is replaced, probably some of the third fluid space build-up is going to resolve. But some of the third space fluid build-up might also be simply her being immobile. That also contributes to swelling. Pressure sores, well, it all comes down to good pressure area care. I would hope that any ICU will not have any patients with pressure sores simply because of, you know, their skill. The ICU team does breathing tests each day to extubate, but hasn't seen a good response. But 5 days ago, she went 8 hours breathing, next day 6 hours, and past 3 days are less than a minute before going back to assisted ventilation breathing. Well, the first question here, Jonathan, is why is that? Have they started resedating her? Is she sedated at all? Right? Is she on benzodiazepines? Is she, such as Versed, diazepam? Is she on propofol? Is she on morphine, fentanyl? Why is she stopped breathing all of a sudden? Is it the dementia? Is it her diaphragm not working? Is she simply tired? Is she not getting enough nutrition? Right? You're also saying she's awake, so maybe she's not sedated or not heavily sedated. She's not appearing in pain, and blood pressure pulse oximeter has somewhat stabilized. She's got electrolytes stabilized, but you know, red blood cells indicate that they're low. You're also saying you are pressured to let her go peacefully with pain management to start before they remove the ventilator. And they say she will likely pass within hours. Well, no one can pressure you to kill your mum. Why would anyone in their right mind let anyone pressure you to kill a family member? So this is something you're obviously responding to, and you are in control of who you are responding to, right? And how you respond. This is something that you are 100% in control of. So why would you let an outsized force pressure you? That doesn't make sense to me. It's your mum, not their mum. And if they let her go, what I put in quotes, peacefully with pain management to start before they remove the ventilator, well, I argue that could be perceived as euthanasia. Now, as far as I'm concerned, in 2025, euthanasia is still illegal. So would you sign off on that? They are saying she will likely pass within a few hours. Well, no guarantees for that. I have seen before where intensive care teams said, oh, you know, if we remove life support, this patient is going to pass away pretty quickly. Well, it's no guarantee. Just as much as there's no guarantee that if you do continue treating, that she will survive. But obviously, you do know that if you stop treating, she won't survive. And it may not happen immediately, but it will happen, probably, most likely. So, ICU doctors say risk of VAP or other issues with current poor health are not surmountable and increase daily if on the ventilator. Okay, so VAP once again stands for ventilator-associated pneumonia. Enough research has gone out there that if you continue ventilating a patient in ICU, whether it's with a breathing tube or with a tracheostomy, that the VAP or ventilator-associated pneumonia is likely to happen. No question about that. But the reality also is if you stop ventilating someone that needs mechanical ventilation to survive, well, they're going to die also. So once again, that is like saying we stop eating and drinking in case food or water is contaminated. That's ridiculous, right? You always have to make a risk-benefit analysis, right? So when they're saying that the issues, health issues with current poor health are not surmountable and increased daily on the ventilator, well, the doctors are saying it's not surmountable. It's something that can't overcome. Well, once again, who are they to say that? Well, one thing is for sure, if you are not continuing to treat, you will know the outcome, which is most likely death. So here's another thing. Approximately 90% of patients in intensive care survive. That is 90. Okay? So 90% of patients in intensive care approximately survive. So why would your mom be the 1 out of 10 not surviving? Have you asked that question? Do you even know the numbers? Right? Is your mom in a real or perceived end-of-life situation? Well, what's the difference? What's the difference between real and perceived end-of-life situation? Well, I'm glad you've asked. A real end-of-life situation is a situation in intensive care where a patient is dying, full stop. Nothing, no surgery, no fancy treatment, no drugs, no equipment, no nothing will save your loved one's life. And death is imminent. That is a real end-of-life situation. A perceived end-of-life situation is what most end-of-life situations are in intensive care. There's a perception. It's not necessarily a reality. As a matter of fact, it's unlikely that it's a reality because 90% of intensive care patients approximately survive. Right? So, and your mom, I believe, is in a perceived end-of-life situation at the moment. Could it turn into a real end-of-life situation? Sure. Sure, it can. But the odds are still in your mom's favor. The diaphragm and the dementia. Look, I'm not questioning for one moment that it is more difficult to get someone off the ventilator with dementia than it is to get someone off the ventilator where the brain is fully intact. No question. But once again, what is the alternative here? What is the alternative here? Not treating, right? That is one alternative. And letting your mom go, yeah, that could be one alternative. Is that the alternative you want? I very much doubt that's the alternative you want, right? I very much doubt that. So, but let's continue. I'm just going back on camera in 1 second while I keep talking. So, the question really is here, what do you want? And it doesn't sound to me like you and your family are ready to let your mom go. And that's okay. That's a good thing. That is a very good thing that you're not ready to let your mom go. So let's continue in your email, Jonathan. I'm reluctant to move the ventilator in hopes she would regain the desire to inhale on her own, but they say dementia likely is causing brain signals to be weak for stimulating diaphragm to take breaths. Yeah, that is probably accurate. That with dementia and is likely to cause brain signals to be weak for stimulating diaphragm to take breaths. Yeah, that can happen. Well, but you don't have any evidence for that just as yet, because you have also said in your email that she was breathing spontaneously for a few days. So you have absolutely no evidence that this is actually what is going to happen. So since her eyes are open and she's salivating and is responding to my touch, or if I do suctioning, I know that she's still aware enough to see me, etc., but I can't communicate to be sure of much more. Well, Jonathan, have you tried communicating with her? So what I mean by that is, have you asked her to squeeze your hand? Ask her to squeeze your hand. That is one way to communicate. So let's just say she can squeeze your hand if you ask her to. Could you get her to answer yes and no questions just by squeezing hands? You know, could you ask her yes and no questions, and yes means squeezing once and no means squeezing 2 times? You know, can you ask her, does she want end of life or does she want to continue treatment? She might have dementia, and I don't know how severe the dementia is, you know, but it doesn't sound to me like it is that severe. I don't know. You haven't really gone into the details there. So the doctor says outlook is poor and pain may exist, but we can't tell as the tube prevents vocalizing sounds to convey this. Yeah, work around that. Go to yes and no questions with your mom. And like I said, with squeezing hands or potentially with eye blinking. Again, if you ask her yes and no questions, 1 blink of an eye is a yes, 2 blinks of an eye is a no. Try that. The doctors will always say that the outlook is poor for most patients in intensive care to stay in control of the narrative. So what do I mean by that? ICU teams are notoriously negative. Notoriously. Why is that? They want to protect their downside. They want to protect staying in control of the narrative. Once again, what do I mean by that in more detail? ICUs are notoriously short of beds, short of staff, short of equipment. So their goal is to get patients in and out as quickly as possible. An ICU's worst case scenario is to look after a patient indefinitely with an uncertain outcome. That is their worst case scenario, because it eats up a lot of resources, takes up a lot of time, and it blocks, quite frankly, it blocks an ICU bed. By them telling you from day one, it's all grim, it's all doom and gloom, your loved one's not going to survive, they stay in control of the narrative, or so they think. By them trying to move your family member towards end of life as quickly as possible, gives them all the leverage, right? Number one, if you agree with it, well, their work is done, right? They free up the ICU bed, the next patient is waiting, you know, short-term goal achieved. If your mom here continues and is not improving and is going to die, they will tell you, well, we told you so from day one. Now, if your mom is improving, right, they can look as the heroes, right, which they have no interest in really, right? They can look as the heroes, you know. So you have to read between the lines whether the outlook is really poor, right, or whether there is a chance of survival. And like I said, you've got to look at the research, you've got to look at reality, which means most patients in intensive care actually can survive, right? So you're saying pain may exist. Once again, ask her. Can she squeeze hands? Can you ask her, Mom, are you in pain? Well, once again, 1 squeeze of the hands is a yes, 2 squeeze of the hands is a no. Right? Now, you're also saying I've been pushing back on their wish to limit or eliminate ventilation support and terminate because of the day 10 to 14 limit. They say ventilation usually follows for a successful outcome. Well, yes, you can consider a tracheostomy as a next step if she can't come off the ventilator. But my question really is, why has she stopped breathing spontaneously? What has changed? What has changed? You know, you're also saying that 8 months ago she was in the same ICU 6 days on the ventilator and recovered to home care and baseline within a month. So what makes you think she can't do it this time? So you're talking about your mom being dementious for the last 4 years, and she had one ICU say 6 months ago and she could come off the ventilator. So what makes you think she can't come off the ventilator this time? Has your mom deteriorated in the meantime? You're saying, in my mind, I'm willing. You're saying, ultimately, we might win a battle, but won't win the war, as it won't make her life much better. Yes, And that is also a consideration you need to take. What would your mum want? What's the quality of life she would deem as acceptable? What's the quality of life she deems as acceptable? In my mind, I'm willing to hold off on the 14-day mark so long as I can see her awake and she doesn't interact with me. Yes, absolutely. She should interact with you, and you should be able to ask her what she wants. I think that is really important, that you get in a position where you can ask her what she wants. So, as I'm the only child and caregiver and proxy, I will have to make decisions as her advocate, and I've done for the last 3 years with dementia and other medical issues like pressure ulcers, wound care. It's not going to be easy to let it go. No, of course it's not. I've been reading through your online materials, trying to grasp at straws of optimism for a possible turn of events, getting off the ventilator even after 11 days on it now. I am backing her into a corner of suffering while I resist the doctor's advice to go with morphine and removing ventilation support. Well, is she suffering? Why are you saying your mum is suffering? Why? Do you know if she's suffering? Can you ask her? I'm sure there's more to consider, but I'm overwhelmed with the idea I'd be pulling the rug out when she may regain the strength or brain signals to get back to breathing without the ventilator. Yeah, absolutely. There is a lot to consider, and I can understand that you're overwhelmed. The other question that I have in a situation like that is, where's the urgency to kill someone? Where is the urgency to kill someone? What's the rush? What's the rush to kill someone? I don't know. Have you asked them? I would put that question to them. Where's the rush to kill someone? Especially when there's a survival rate of 90% of patients in intensive care survive. Now, here's another thing. Let's just say she can't come off the ventilator. Let's just say she's not waking up, despite all the sedatives have gone, all the opiates have gone, she's breathing spontaneously, but she's still not ready to be weaned off the ventilator, right? She's not ready for whatever reason. And she has a tracheostomy, right? Yes, one could argue that opens up another can of worms, but the other argument is it will help her to buy time and see whether she can wake up, right? To see whether she can wake up, And if she can wake up, then you can make her own decision. I should say, she can make her own decision, right? Which is what choice and control is all about. And even with dementia, I'm pretty sure she can tell you whether things are comfortable for her or not comfortable. So, the other thing that could come out of this, and Jonathan, I don't know where you are in terms of location, but another thing that could come out of this, if she ends up with a tracheostomy and you think that's a good solution, at least in the short term, that also opens up the possibility for intensive care at home, right? With intensive care at home, your mum could go home with a ventilator, with a tracheostomy, with a PEEK line, with a central line, with a PEG tube, nasogastric tube, whatever she needs, right? And that's a genuine alternative to a long-term stay in intensive care. But that's only really if she can't come off the ventilator and you then go on to have a tracheostomy done, right? But it's not there yet. But you need to understand your options, And with intensive care at home, you can cut the cost of an ICU bed by 50%, 50, which means that, a funding body, a funding organization, whoever's funding the ICU bed at the moment, will fund intensive care at home. Very simple. you know. So, but the other thing that still needs to happen here, they need to clear the ARDS, which is challenging in and of itself. You know, clearing the ARDS won't be a simple sort of thing either. You know, and her CO2 levels need to come down, oxygen levels need to come up. So there's a fair bit of things that need to improve, of course. You know, but don't be pressured. Don't be pressured. Put the pressure back on them. Put the pressure back on them and ask them to do whatever it takes. Different approach, different thinking. Right? So, I hope that helps. And let's look at the next question. Let's look at the next question. That comes from a dietitian who's Sarah, who says, "Hi Patrick, I have a client who has a perforated small bowel and a stoma bag in situ. Previously, due to stomach cancer, he had stomach surgery done to remove the tumor. Recently, he was called back by his hospital doctor to readdress, fix the perforated bowel. He was on TPN while in hospital. I would like to ask, is TPN at home a possibility? And if so, how about does he access TPN at home? He's under home care package in Australia. I look forward to hearing from you." Yeah, sure, we can do home TPN. We can do home TPN for a patient like this. This is from Sarah, dietitian in Perth. Yeah, we can absolutely do this. I'll go into detail in a minute. Peter is asking, ARDS, what helps repair the white spots to regain lung function whilst on the ventilation? Look, I don't know, Peter, what helps repair the white spots to regain lung function, but the white spots are usually a result of the infection, right? So what helps is to target the right antibiotic, antiviral, antifungal, depending on where the infection is coming from. You know, that is usually what helps to repair the white spots to regain the lung function. How it works on a micro level, I don't know. I wouldn't know. Or what leads to the poor triage in a failed de-intubation or re-intubation. I don't know what you mean by that. I can understand it's not necessarily a poor triage in a failed intubation, not automatic. I don't know what you mean by poor triage, Peter. You know, I tell you what can lead to failed re-intubation, to lead to a failed intubation, no, to a failed extubation. I can tell you what leads to that. Probably often poor selection of the time window when to extubate, right? It all comes down to choosing the right time window when to extubate to avoid re-intubation, right? And there's clear parameters when to extubate, clear. You know, every ICU has them. Sometimes there are more risky extubations than others, of course. Sometimes you do need to take a risk and see whether, and sometimes you have to take a sink and swim approach. I'm not for it, but sometimes you may have to. Isn't it a poor assessment if the breathing stops? Yes, it would be. It would be. It would be a poor assessment if the breathing stops, for sure. They would have chosen the wrong time window. Absolutely. Or didn't have the right tools in place, i.e., so let's just say you're extubating and you're not quite 100% sure whether it's working or not. Well, at least you need to have non-invasive ventilation ready, such as BiPAP or CPAP. Yeah, no, I get your point now, Peter. I get your point now. You're basically saying someone's made a poor assessment when to extubate, which led to re-intubation. That's basically what you're saying. And by the same token, Peter, I'll give you an example here when, let's just say, someone needs to be extubated, but you know the risk is high. I'll give you an example. So let's just say someone is breathing on CPAP or pressure support, They're breathing on 35% of FiO2. They're breathing with a PEEP of 5. They're breathing with a pressure support, let's just say 12, 10. And they're sort of day 10 to day 14 on mechanical ventilation with a breathing tube. And you think, should we do a trial extubation or should we do a tracheostomy? Now, if you do a tracheostomy, you are potentially doing a surgical procedure that can be avoided. If you're extubating and the patient fails, well, you know the patient needs to be reintubated. But there's also a chance that in a situation like that, where it's sort of borderline, it also depends on chest X-ray, it depends on blood gases, it depends on the cognition of the patient. You know, there's a number of things you need to look at, of course. But the bottom line is that when you're not extubating and you go straight to a tracheostomy, is that the right thing to do? Do you need to take that risk? And I think you should do a trial extubation in a situation like that to see whether it works. And then put the patient on BiPAP, potentially, or high flow nasal prongs. Does that make sense, Peter? Does that make sense? If you are extubating and you need to intubate within a couple of hours, your judgment was off. So then you're saying requiring an IHRS for reintubation. What do you mean with IHRS? What do you mean by that? What do you mean? Day 7, I believe, in ICU for the failed reintubation. So 7 days without intubation, no trach, yeah? Okay. So one could argue that 7 days without ventilation gave the patient a better chance of not having a tracheostomy. You could argue that. I don't know the ins and outs. What do you mean with interhospital transfer service? Requiring interhospital transfer service, okay. Oh, that means you would have gone, or the patient would have gone from a hospital ward back to ICU. Is that what you're saying? Is that what you're saying with the interhospital transfer services? Okay. Are there any other questions? Because I can see there's quite a few people here. If you have any other questions, please type them into the chat pad or talk to me directly. You can talk to me directly by clicking on the StreamYard link that I'm just posting in the chat pad now again. Just click on the link and you can talk to me directly. We have another 20 minutes to go. I will wrap this up after an hour. We're roughly 40 minutes in. So you still have time to talk to me directly here or type your questions into the chat pad. If there are no other questions, I will just go back to the emails that have come in during the week. So there was a question from a dietitian about home TPN. Yes, absolutely, we can do home TPN, right? For the patient that Sarah there was providing. But the patient needs to have a PEEK line, central line, Hickman's line, or a porta cath, right? That is what needs to happen. So let's go back to other questions that have come in during the week, if there are no other questions. And if you do have any questions, type your questions into the chat pad or click on the StreamYard link and talk to me directly. Someone's asked this week, please tell me the 3 biggest mistakes made in regards to ventilation and tracheostomy. Please help ASAP. Yes, I do have an ebook about that. But the 3 biggest mistakes in regards to ventilation and tracheostomy, as far as I can see, is number 1, families don't know that the goal always needs to be to avoid a tracheostomy in the beginning of an ICU stay. That's number 1. The goal always needs to be to avoid a tracheostomy to begin with, right? How? Well, by trying to wean a patient off the ventilator and the breathing tube as quickly as possible. Now, And I've written an article and made a video about it, how to wean a critically ill patient off the ventilator and the breathing tube, okay? And you also need to ask the intensive care team right from the start, what are they doing to try and wean your loved one off the ventilator and the breathing tube beyond the shadow of a doubt, okay? So then, next question, next biggest mistake, right? When patients are being weaned off the ventilator to avoid a tracheostomy, right, they need to be off sedation, they need to be off opiates, they need to have physical therapy, breathing exercises as much as possible, right? Again, patients and families don't seem to understand that. They do not seem to understand that. Well, as a matter of fact, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for, they don't know what questions to ask, they don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's the biggest challenge. We're dealing with this every single day of the week. And the third biggest mistake is that when patients do have a tracheostomy, right, let's just say it's unavoidable, let's just say tracheostomy is the next step, and we all agree on that, and then the patient can't come off the ventilator and the tracheostomy for whatever reason, that intensive care at home is an option. Well, and what I mean by that is patients and families don't know that intensive care at home is an option. So if you do need to agree to a tracheostomy, if you want to agree to a tracheostomy, keep in mind that with a service like intensive care at home, a lot is possible at home. Quality of life, cutting the cost of an ICU bed, but more importantly, quality of life. There's no quality of life in an ICU if you're stuck in there long-term ventilated. There just isn't, right? No matter which way you want to twist and turn it, there simply is no quality of life for a patient with the tracheostomy and ventilation in ICU, right? So keep that in mind. So then I also actually want to read out a testimonial that's just come in overnight. And it's with a client that we worked with for many months now. Just want to quickly read it out. Here it is. This is from Katie in Oregon in the US. She says, "Hi Patrick. Patrick Hutzel is assisting my family and myself with our dad in Oregon. Thank you all so much for sharing your time and knowledge with us. I know my dad would not be with us now if not for the expertise of Patrick Hutzel and Intensive Care Hotline. Again, we are also very grateful to have been fortunate enough to have him, that meaning myself, take a look at his case. Keep up the fight," from Katie. Well, Katie, thank you so much for your kind words here. And just for context, so this is a man in his early 80s. He is in the US, he's in Oregon, and he was admitted to ICU a few months ago, might have been before Christmas, can't remember now, would have been around Christmas, with a cardiac arrest and hypoxic brain injury. And ICU was adamant from day one that at his age, the best option is to just let him go, let him die, let nature take its course, because even if he was to survive, he won't have any quote unquote quality of life. Family was adamant that this is not the way to go with their dad, that he was active, prior to this, and that he would want to live. That was their approach. And ICU was almost blackmailing them in terms of, they didn't want to do a tracheostomy. It was a horrible, horrible situation. But in the end, with our help, with our advocacy, with our insights, we got the tracheostomy done. And that gave the gentleman time to wake up. But here's another thing that I remember about this case in particular, right? The family couldn't get access to the medical records initially until we helped them. And when we looked at the medical records, I remember that he was actually on Presidex, which is a sedative. And the family basically had been lied to. Basically, they were saying he's not on any sedatives, right? That is why I'm saying, unfortunately, you can't trust. You have to verify. And you can only really verify. The ways to verify is by, if I do one-on-one consulting, I talk to doctors and nurses directly. I ask them all the questions that you haven't even considered asking. But also when we look at medical records, we pretty quickly get to the bottom of things and we'll find out what's really happening. Most of the time, ICU teams are not even telling families half of the story. Not even half of what's happening. When we look at medical records, we always find out, oh, this is what they haven't told you this, they haven't told you that, right? It's just the reality. It's just the reality, right? And you need to take responsibility for getting the outcomes that you want. You really do. You really do need to take responsibility. Okay, another case that I want to quickly talk about is a patient that we're also working with at the moment, or a client, 51, 52-year-old man with also after cardiac arrest and potentially with hypoxic brain injury, ended up in ICU on ECMO for cardiac failure. And he was on ECMO for about 3 weeks, touch and go. He then got decannulated, i.e. ECMO got removed. Bear in mind, this is VA ECMO, veno-arterial ECMO for heart failure. There's also ECMO for lung failure, but in this situation, it was ECMO for heart failure, right? And with a heart failure, the patient was on multiple inotropes, epinephrine, norepinephrine, was on amiodarone, lignocaine, because he had a VF arrest, so his heart was very unstable. Eventually, the patient could come off the ECMO and was put on an impeller. Impeller is another device that supports the left ventricle of the heart, right? That looked like in the beginning it was just a little bit too premature, because the minute they put him on the impeller and removed the ECMO, he went on to nitric oxide to support his lungs because the heart couldn't cope initially. He went back on inotropes and vasopressors such as norepinephrine, levophed, vasopressin, and the works. He also was on heparin, of course, during the ECMO, as well as the impeller now, right, which is an anticoagulant or a blood thinner, making sure it's not ending up with a stroke, right? It was touch and go. Cardiac output was low, cardiac index was low, his mixed venous oxygenation was low, right? Eventually he came off the nitric oxide, right? Eventually he did have a tracheostomy. He couldn't come off the ventilator once they removed him from ECMO, right? His ejection fraction is still pretty poor. Ejection fraction basically refers back to the contractility of the heart, right? And, it is slowly improving. It is slowly improving. And he's also now on CPAP trials or on spontaneous breathing trials, right? It is a long process, right? It is a long process, but our client here is also waking up. He's squeezing hands, he's communicating with his family, right? Which is really good. Which is really good. So after weeks of being in ICU, he's still alive. It's going to be a slow process, but also, again, the whole notion from the intensive care team initially that, his hypoxic brain injury would not allow him to wake up is not accurate. He is waking up, right? So we see this over and over again, that over time, patients that are being deemed as, hypoxic brain injury and they will never respond, that is sometimes accurate and sometimes it's not accurate. Patients do actually wake up and they can communicate, right? Will they be back at baseline? You only find out once a patient is out of ICU, maybe has the trach removed, at the end of the day, you never know. But the family is adamant here that, that dad wants to live. Also, I'm just looking through the reports now. Even the trach collar trials started on the 7th of February, right? So there is a lot of progress to be made for these men. Helene says, dangerous sedatives that were lethal amounts poison were concealed from me concerning my late mother at WSAMCS. Yeah, Helene, I'm very sorry to hear about that. You know, I'm not sure whether you had access to the medical records at the time, because, you know, something like that should be documented in the medical records. And this is exactly why we, here at intensivecarehotline.com, why we highly suggest and recommend that you get access to the medical records day one. Very simple. You got to get access to the medical records day one. You know, you didn't have access to the medical records. You know, you also got to get an advocate from day one. You do. You know, unless you're a medical professional, but even if you're a medical professional, you know, some of our clients are nurses. Some of our clients are nurses. Some of our clients are nurses that do not have ICU experience, and they know they don't have the expertise. Some of our clients are even doctors. We had doctors as clients. For example, we had GPs, like family doctors, as clients. You know, because intensive care is such a highly specialized area that unless you know what you're looking for, unless you know what you're doing, you really have no idea. You know, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. At that time, I only had hospital risk management, says Helene. Yeah, the hospital is managing the risk for themselves, not necessarily for a patient. Peter says, I would like to reassure viewers that a hypoxic injury is difficult but not always terminal. Yes, and thank you, Peter, for sharing that. You know, I know we've had viewers on this channel saying similar things. You know, thank you for sharing that. I think that is really, there's a lot of insight there, Peter. You know, so yeah, this is what's happening with this patient. And we had, there was one session here, the patient that I'm referring to here, that the patient that I'm referring to here on ECMO and now on the impeller with the tracheostomy, I had a session here with a family member on the YouTube Live maybe 3 weeks ago. You can actually look up the call there about 3 weeks ago. Yeah, ask questions like Patrick states, be informed. Yes, yes, absolutely. You know, the challenge also is, and I get that, you know, no one's sitting at home thinking, oh, what if my mom, my dad, my spouse, my child, God forbid, goes into ICU next week? What questions do I need to ask? I know no one's sitting at home thinking like that. I get that. And no one wants to sit at home thinking like that. Of course not. It's very confrontational, you know. But when you know, for lack of a better term, shit hits the fan, what do you do then? You know, what do you do then? You know. And the other thing that I want to say, for those of you that were here last week, there was this family here on this call from the UK who had their dad, or might still have their dad in ICU with pulmonary fibrosis. He's only 66, and you know, I said to them, well, why can't he have a lung transplant? You know, I haven't heard from them, but you know, I haven't heard from them. But what I did hear from them this week is I gave advice how to remove the DNR, and they said the DNR was removed just as part of the call that I had with them here. You know, that is good to know, of course. You know, I do want to know what the feedback is. Yeah, so Elaine, you're saying sink or swim. Yeah, there is a bit of that. There is a bit of that. There is sometimes sink and swim for patients, or sink or swim for patients, and sometimes there's sink or swim for families as well. You know, it's a very tricky environment, and you wouldn't wish it to anyone. You wouldn't wish it to anyone. You know. So, But anyway, here we go. Now, are there any other questions before I slowly wrap this up? I have time for another question. So we've done that. It needs to be a short question. Good afternoon. Hi, this is from Isaiah, who says, "Hi Patrick, I'm reaching out to you in regards to my mother who has been in ICU for about 5 days now due to brain hypoxia from cardiac arrest. Since it's been 5 days, the doctors want us to make a decision by tomorrow or Monday about my mother getting a tracheostomy. I wanted to do a 60-minute Zoom call with you so my family can make the right decision." Yeah, for sure, you can do a 60-minute Zoom call with me, for sure. Given that it's only day 5, Isaiah, it's too early to do a tracheostomy. It's too early. Comes back to what I said earlier. What are they doing beyond the shadow of a doubt to get your mum off the ventilator and the breathing tube and avoid the tracheostomy? Goes back to that, full stop. That is the question you need to ask. You know, what are they doing right now to get your mum off the ventilator and the breathing tube and avoid the tracheostomy? Tracheostomy should not be considered after day 5 unless patients, God forbid, are C1, C2 spinal injury, motor neuron disease, you know, God forbid, something like that. Yes, you can probably safely move towards a tracheostomy, but that's not what I'm hearing from your mom's situation here, Isaiah. Okay, I do want to wrap this up in a minute. So if you want more information for consulting and advocacy, hang on, Helene says, "Mom extubated herself because no tooth guard was placed when she was intubated. She suffered iatrogenic induced hypoxia, permanent brain injury." Yeah, I'm very sorry, Helene, to hear that. You know. Okay, so if you want more information, go to intensivecarehotline.com. I do one-on-one consulting there. We also have a membership for families of critically ill patients in intensive care, where you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. It is a paid membership, but you know, we help so many members now, and we can help you, you know, join a growing number of clients and members that we help. And I am very confidently saying our advice is absolutely life-changing. It is absolutely life-changing, and I'm not exaggerating here, right? With intensive care at home, once again, we are sending our critical care nurses into the home 24 hours a day for long-term ventilation tracheostomy. We're providing a genuine alternative for long-term stay in ICU, which includes BiPAP ventilation, CPAP ventilation, tracheostomy care without ventilation, home TPN, home IV potassium, home IV magnesium, PICC line management, central line management, portacath, nasogastric tube management, PEG tube management at home. It's all covered with our critical care nurses at home. We are currently operating all around Australia in all major capital cities and all regional and rural areas. I've got to wrap this up for today. Thank you so much for your support. Like the video, comment below what you want to see next, share the video with your friends and families, and subscribe to my YouTube channel so that you get all the updates. And I hope I'll see you again next week around the same time. Take care for now.